Okay, let's have a class. We are going to have lots of information today. Some sections will be combined, and we will have try to finish as much as we can. And then on Thursday we have a little bit left, but the majority of the time on Thursday we're going to do the practice exam questions. We're going to talk about each one of that. And you can see we have lots of the case study. So you better to do that before, at least take a look. Then we can talk about those when the class starts, okay? So today we want to focus on the sexual transmitted disease, STD. That is what it is for. We gave you some of the examples, STD. So sexual transmitted disease. First of all, sexual transmitted disease is 95% is from male to female. This is based on 20 years of the surveillance results and said very easily or a little bit rudely, which is a contaminated penis into a vagina tract and then cause all the problem. And 95% is from male to female. Sexual transmitted disease, there is no very effective vaccine. So that means we don't have shots for you. We don't have drugs to prevent that. It does not mean you take a couple of shots and then you can do whatever you like. So there's no effective vaccine. And they also no, we say long-term immune protection. So what this means, you got one time sexual transmitted disease does not mean the rest of life will be safe. You get syphilis does not mean you're not going to get syphilis anymore. So there is no long-term immune protection. There is also something happens is roughly 70% is asymptomatic, which means they did not show any of the symptoms. People didn't realize that. Number 5. This is always debate in the area, is this a scientific problem or a social issue? Which means the medical doctor says we may need more work to prevent or protection or do some precautious work, proactive work to prevent sexual transmitted disease. But the social scientists will say we may need to do more education. This is the topic, it's a debate point. We will have a final exam, extra points, extra essay writing for 25 points. We'll talk about that. And the essay topic I will post it on the eCampus sometimes November, and you go ahead to work on it. In the final exam, in the classroom, you're going to write handwriting 250 words to 300 words about this topic. Because undergraduate is a risk group for sexual transmitted disease. So we want you to do some after-class reading and talk about that, okay? And you can see on the slides, it's a severe public health problem. It's going to cause 300 million new cases every year. More frequent is 50 to 30-year-old group. And obviously, all of you fits this group. That's why we have this topic for you to work for the extra points of the AEM 341 the whole semester, which is you do some of the self-education. There are lots of the sexual transmitted disease. We will pick a couple of them. We basically pick 2. And we're going to talk a little more detail. So first thing we want to talk is Neisseria gonorrhea. Neisseria gonorrhea. H-O-E-A. Okay, Neisseria gonorrhea. Since this is already called, it is Neisseria. Therefore, this bacteria, the characteristics is same or highly similar to Neisseria meningitis. It is a gram-negative Coccobacillus. Looks like a bacillus, looks like a cocktail, and this is also coffee bean shape. So what it looks like this, like a coffee bean shape. Okay, it is a fastidious bacteria. What means fastidious bacteria? On the clinical area, we have Macanchi agar. We have blood agar. And we also have chocolate agar, or we say chocolate light agar. Light agar. It did not grow on Macanchi agar. It did not grow on blood agar. It only grows on chocolate agar. And specifically for Neisseria gonorrhea, this is going to grow on modified Shea Martin chocolate agar. We say modified Shea Martin transport media. Okay, what are the symptoms for gonorrhea? For female, it's little difference. A male is very obvious. Is a contaminated penis has a pus generator. It's that simple. It looks like the picture. The abnormal pus generator accompanied with dysuria, which means difficult to pee, abdominal pain, and slightly fever. For female, basically it is you have abnormal bleeding during the arm period of time. You have liquid extracted from the vaginal tract. You have abdominal pain and all kinds of uncomfortable in a lower body. That's a little complex with every symptoms. But so this is a typical symptoms for gonorrhea. This is also fits what we just say. 95% of them are male to female. Now, as a microbiologist, what we really want to talk about is how we determine it, how we diagnose it. From male to female is a little bit different. How we diagnose it. Okay, from the male, we usually get the pus. We do streak plating. And then, we're going to go ahead to do the gram stain. And if the gram stain characteristics, which is shown completely fit this, and in other words, it looks very similar to the picture above. You see the coffee bean shape, gram-negative diprococcal, surrounded by the red blood cell or white blood cell. That is gonorrhea. That means inflammation. So that's a gonorrhea. And then the colony, we also go to modified Shea chocolate agar, and together we go to reference lab to do a final recording and determination. So that is for male, how we do it. For female, what do we do? For female, we do not do these two steps. For female, we get vagina extract. We directly streak plating onto modified Sayre Martin media. And then from there, we pick the colony, we do oxidase test. We were talking in the lab, what is oxidase test? It needs to be oxidase test positive. And then this plate's also sent to the reference lab, we do the final confirmation. For female vagina tract sample, we skip gram stain. Why? We don't do this. The reason is the female vaginal tract, there is a multi-million bacteria there. For example, lactobacillus. For example, some the Candida albicans or other eastern modes, other bacteria. It's very difficult to do purification, and also very difficult to do the gram stain. When you do the gram stain, you're not going to see the colony morphology very clearly. So we get this extract from the vaginal tract, we directly streak plating onto the modified cyanotic media. We get the colony, we do a quick oxidase test. If it is positive, then we send it to the reference lab. So there are difference between the diagnosis between female and the male. And also very easily happens all the time is you see the newborn baby has a conjunctivitis. And this is not the eye problem, not the inflammation of the eye. It is a newborn gonorrhea. This is basically come from the pregnant woman. If the pregnant woman has gonorrhea, it could be easily transferred from the fetus and go to the newborn. Okay, so that's could cause newborn gonorrhea. How we do the treatment? There is basically not very much we can do if you diagnose it. Certainly using antibiotics. Let's say using penicillin. Of course, that's kind of the way we're going to do. But penicillin resistance is a common issue. And we're going to mention penicillin real quick, about like 20 minutes. I was spending about lots of time talking about the penicillin. So we can do lots of the quick tests, like we just mentioned, or using the DNA probe test to do some of the rapid testing. But like what we wrote here, for gonorrhea, the public health education is important for all these sexually transmitted diseases. When you get it, it is very difficult to cure it. And the only thing what you can do is do the prevention. That's why the education is important. Okay, the next one is called syphilis. That's a very hot, important topic in the history. You look at these terrible figures or terrible pictures, you will know how severe it is. Syphilis, when they started, and I hate to say this, it is started from the Asian country. Around even 1,000 or 1,500 years ago. As long as there is a human being, they will have this sexual the first to recognize the sexual transmitted disease in the world. If you look at those old essay or old poem, old novelty, all those things, in those Asian countries, what they have is that those well-established business like nightclub, adult nightclub in here. And more than that, to be honest. And later on, with all the revolution, with all the politics things happens, all those facilities later on become a very fashion restaurant. But I just tell you that the history for that and the syphilis is calling from that. And the people spending, the medical area spending about 200 years or 150 years trying to cure the syphilis using traditional medicine, herbs, all those things that did not get successful until the antibiotics created. So that's why today we talk about the syphilis. We real quick we're going to move on to jump into talking about antibiotics. Before we talk about the syphilis, we want to go over something very simple. We review something. That's called spiral sheets. So you should remember when we do the exam 1, we had a picture talk about spiral sheets. So what is that? This is a very special bacteria. This bacteria is basically looks like this. Asexual filaments. And how they go inside of our body is from cuts, from bites, from abrasions. Because this is asexual filaments, therefore make its structure is very special. So for example, they do not have real well-established cell wall. They do not have a well-recognized flagella. So we call it endoflagella. And because it's very special, so we cannot use traditional established gram stem to do it. What we have to do, if you remember, we have to use dark field microscope to do the observation. And for the spiral sheets, we will introduce you to. One is syphilis, another one is Lyme disease. So let's talk about syphilis. What are the species will cause syphilis? Treponema pallidum. And this is a sexual transmitted. It is also congenital, which means the newborn baby could have syphilis from pregnant woman. It is very interesting. Syphilis has 3 stages. Primary stage, somehow 7 to 1 months. What will happen? On penis, you have ulcer. And they give a French name, chancre. The secondary stage, that's 1, that's 2. Secondary stage, if you have a human being like this, this is what's going to happen. The whole body rash. We have another French name called boomer. What happened? The problem is, when you have an ulcer, we call it a chancre, and then you go to the guma. If this is severely happens or directly happened or naturally transferred, then people will recognize it. The problem is, this is gone. Couple of days later, sometimes 15 days later, the ulcer is gone. So what are people going to feel? They feel I'm recovered. So they can do whatever I like. And then, at the same time, they have a whole body rash. But this rash, people doesn't recognize it. You can think about it's maybe the skin infection. Is that right? You think about that. You do sexual activity every day, night, and you do about a month. You go different places. It could be a skin infection with some normal bacteria or with some fungi. So you didn't realize that this is sexually transmitted disease. Then you have this rash. This rash could be stay there about 1 to 3 months. And then they go to the next stage. The final stage, where you see here, called the tertiary stage, that's actually will cause neurological symptoms. This is will be neurological symptoms, like difficult speak, difficult double vision, difficult swallowing, but that's very later stage. And this stage, when they develop to here, this could be a year, could be 3 years, could be more than 15 to 30 years. Or people could be carrying like this the rest of their life. And what happened, this rash also could disappear, or recovery, or relieve a little bit. So this is a typical example. What happened is for a long-term, well-recognized sexual transmitted disease could be looks like asymptomatic for a long period of time. And then people continue to do sexual activity, and then they transfer to everyone. So that's the risk for the syphilis. So when you look at it here, you can see the picture. You have the ulcer, you have a guma, all these things happens. It's once you go into the next stage, the primary stage symptoms will be recovered a little bit. So that's really confusing people what it looks like. But later on, when they go to the neurological symptoms, some people could go real quick, couple of years, some people could be 20, 50, or 30 years, which means the rest of your life you carry on this horrible spirochetes. Okay? So, and also this pathogen is very penetrating or invasive. So, like we said, same as the other bacteria, once you have the syphilis, it's not easy to be determined. It's not easy to be treated. You do antibiotics in the early stage, but more important is also the public education. Okay, that's why it is a challenge to really solve the problem of this sexually transmitted activity. So we mentioned about here, gonorrheal syphilis. We have another one we mentioned earlier, which is Staphylococcus saprophyticus. Is a honeymoon bacteria. That's another pathogen. It's very common in the 25, 27-year-old sexual activity lady will have that. So those are the 3 pathogens. Is mainly focused on the sexual transmitted disease. Okay, Lyme disease. Lyme disease, the same category as syphilis, but this is a different topic. It's also a spirochetes, and the pathogen name called Borrelia burgdorferi. Burgdorferi. So, Borrelia is genus name, Burgdorferi is species name. Dr. Burgdorferi is a professor at Montana State University, microbiology department. Back in 1970s, he is the first person discovered the spirochetes. So what is that? What is we call Lyme disease? What is Lyme? This is a Lyme County in Connecticut, northwest. If you look at the picture, on the top you have a Maine, you have New Hampshire, then you go Massachusetts, Connecticut is right here, Rhode Island, New England area, typical New England area. Okay, this deep red area. The Lyme County in 1970s, there is a small outbreak happen. And all these patients, they show a very typical symptoms. What are the symptoms? On their arm, they see a rash. And this rash is target rash, like a bull eye. And we have the picture for that. This is the typical symptoms for Borrelia burgdorferi. And it is Lyme disease, if you have that. Now, where they come from? This is one, we have the slides for you. This is not really all of a sudden happen. It is a 2-year program. Looks like the master degree program. You can see, in the year 1 where they comes from, they have those eggs. Where the eggs comes out, it's from the larvae. A larvae will be generated. The larvae carry on Borrelia burgdorferi. And then they find the mice. So the mice looks like is a host, an intermediate host. And then they will generate the fecal samples or spread something to the environment. And the human being will got it. Now the human being does not got it from the mice or from the environment sample. Where they got it? From the ticks. And the ticks is isodex ticks. And these ticks carry on this pathogen. And they go have a bites for the human being, and the human being got it. Remember, spiral sheets, cuts, bites, and abrasions. Bites is one of them. So then the human being has it. And then, if you didn't recognize it, you will be transferred from your fecal sample, and then the mice will get it. And then in the next year 4, it could be transferred to a deer. So the deer looks like is an end host. And the deer has a fecal sample or have something transferred to the environment, and the isodex ticks also got it. And then they spread with the larvae, become a nymph, and then become another isodex ticks. So this is a transfer program like a host, like a parasite. Now, how are we going to control it? There is no way we're going to have to do the deer. You can do deer hunting, but you cannot say, I'm going to kill all the deer. And how about the mice? There's no way in the environments you're going to kill all the mice. So what we can only do is in our life environments, we can well control the isodex ticks. So the ticks control is one of the methods, appropriate way to well control the Lyme disease. This is the pathogen usually for the people to do aquatic activity, like deep ocean fish, like ocean swimming, or all kinds of the diving, all kinds of those active aquatic sports activity. Those persons usually have to do an annual inspection or annual checkup for Lyme disease, whether you have Borrelia burgdorferi. We usually using a PCR methods or using a rapid test kit. But more importantly, if you show that symptoms, which means you get the Lyme disease. Okay, so that's a very typical symptoms for the Lyme disease. This is something I already mentioned, that you're using a diagnostic serological testing, isolation spiral sheets, although it's difficult, and using the PCR testing. Now, antibiotic therapy is, of course, effective, but more important is to control the ticks. Is isodex ticks the control? It is important. Okay, we finished this section, and we mentioned all the time, what we're going to do the treatment. The treatment is from antibiotics. So we're going to spend in time talk about antibiotics. And I would love to directly jump in and skip a couple of slides directly to the topic, what we're going to cover today. And then the rest we can go over it if we get extra time. So we talk about the antibiotics. it took people lots of the time to find antibiotics. The first person find antibiotics is Paul Ehrlich. He is a German scientist. Why he find it? What's the purpose to find out antibiotics? Because of the syphilis. Because the syphilis caused a big problem. So he created Cervacin. This is an effective or first created antibiotics to cure syphilis. And honestly, this is just a dye. It's not really something like magic. It's just like a dye. And how we know antibiotics? When we first know antibiotics is coming from penicillin. That's a well-recognized, and everybody heard about that. But what is penicillin? There's a little history about it. Penicillin first found by a people in 1892. Ernest Dustrin, the last name, I want to double check, the last name is Duchesne. He is a French student, doctorate student, studied medical science. He's the first person to find penicillin, and it is coming from penicillin, which is a fungi. Basically the moles. But it didn't do anything by the time, he just find it. Who is the person really making this a big topic? This is everybody knows. Alex Fleming. Alex Fleming in 1928 find penicillin have a very strong antibiotic activity. How he did it? It's very simple. I'm going to grow Staphylococcus aureus. And then I'm going to also have a penicillin here. What do you find? Everything else on the agar plates is pretty messy. The only thing is surrounding this penicillin. This is transparent zone, which means no bacteria is growing, it's curing bacteria. So Alex Fleming is the first person who find it. But then later on, we have to verify. They have a very good antibiotic activity. So there is another two scientists they did it. This is around 1930 to 1940, which is the two scientists' name is Howard Florey and Ernest Chen. These are two great scientists at Oxford University. Why I want to mention those two scientists? What they did an infectious study. In mice. And they find penicillin can cure Staphylococcus and Streptococcus. That's why we want to talk about Staphylococcus and Streptococcus, because Back 150 years, 100 years ago, this is a big risk in the world. Right now, we all talk about is E. coli 157H7, Listeria, Salmonella. By the time, this is a big risk. So, in order to honor Alex Fleming, Howard Florey, and Ernest Chen, in 1945, the Nobel Prize is awarded to three of them. So that's a history, a little bit of history about penicillin. Another thing happened in the history of the antibiotics is Budgie and Wassman discovered streptomycin. You heard streptomycin all the time. Why this is important? Because it's solved the problem of tuberculosis. Remember mycobacterial tuberculosis? Start from Bob Koch spending almost 70 years trying to find a way to do until Wassman discovered the streptomycin. And I always said that tuberculosis in the older time is like a lung cancer. It's even severe than that. When you get it, you die. There is no way to do the treatment until streptomycin has been discovered. So those two things add up together is a milestone in the antibiotic medical treatment history area. So that's why we want to spend some time talk about the penicillin. And I'm going to jump here, go to the very end, talk about that. And this slide is also important. So we want to talk about the penicillin. And we talk about the penicillin, we could review a lots of information. So during the development of the penicillin, people studied the bacteria cell wall structure. And we already talked about that, but we can do some of the review. What are the bacterial structure, cell wall structure looks like? The cell wall structure, especially for gram-positive bacteria, they have a very important structure. It's called peptidoglycan. What do they look like? They composed by two very important modified sugar. Is NAM and NAG. Do you still remember what they called? NAG, this is NAM. NAG, this is also NAM. They do the alternate range. And they also connected with each other. So bacteria cell wall peptidoglycan, composed by what? Modified sugar, NAN. N-acetylmuramic acid. And what is NAG? N-acetylglucosamine. What else we needed? Amino acids. Is that right? Here is all amino acids. What of the amino acids is important? Is alanine. What is alanine looks like, by the way? That's alanine. Okay. So what we do? You have amino acids. You have a glucose, modified sugar. When they build this, they need an enzyme. What is this enzyme? Called PBP. Penicillin binding protein. This actually a transpeptidase. Transpeptidase. Remember, bacteria, when they're building a cell wall structure, they have amino acids. They need to become a peptide first. When they build up the peptides, they need the enzyme to help. It's called transpeptidase. During the history, when people study the mechanism of the penicillin, how they kill bacteria, they find this enzyme. And very ironically, they name them penicillin binding protein. So this is what it originally looks like. And then how they do? When the penicillin come in, let's say this is penicillin, they attack to it. So we'll stop the working of the transpeptidase. Let the transpeptidase stop working, so transpeptidizing will not happen, so they're not going to build up these middle line, so they can kill the bacteria. In other words, when we talk about this mechanism, what it tells us? It tells us penicillin basically more effective for growing bacteria and more effective for gram-positive bacteria. Because gram-positive bacteria have a heavy peptidoglycan. And when the bacteria are growing and they're building the peptidoglycan, you can stop that. And you're going to attacking the penicillin binding protein, which is transpeptidase. Now the question is, how come penicillin can do that? This regarding the structure. So we're going to talk about that. In the very early time, penicillin, we call it a penicillin G. It is a natural one. What it looks like? It is a very interesting structure. Let me double check it. Goes here, yes, go here. That's penicillin G. What is that? 6' amino penicillinic acids. That's acid. This structure is very complicated, it looks like. But what's the key? It's here. This structure, you may learn in the other classroom, beta-lactam. And this beta-lactam could attacking the penicillin binding protein, could stop the working of the transpeptidase. And that is penicillin G. Penicillin G is naturally generated from penicillium. But there is a restriction. There is a severe restriction. What is the severe restriction? This is only for gram-positive bacteria, which means narrow spectrum. It's not going to work for gram-negative bacteria. Only for gram-positive bacteria. It is acid susceptible or acid liable. What this means? You cannot orally take it because stomach acid, the environment is only pH 1 to 2, will hydrolyze it. So in the older time, even when I was young, back like 1980s, If we need to take the shots, we need to take penicillin, what we do? Take the shots at the butts. That's the only thing. So we always make a joke for the naughty boys. We say, if you don't happy, we're going to take you to see the doctor and give us shots of your butt for penicillin. Because that's the only way we can do. And also, this is a large molecule. It is difficult to penetrate on the muscle. So what happened? After like 1 month, and every day if you take the shots, you have a big swelling area of your butt. That makes the clinical using very uncomfortable. So there is a restriction for that. So later on, people started to develop something. How they develop? This area, they do not change. They change basically here. The first one they change. They add a carbonyl group here. Then they go CH2, then they go C, then go NH, and connect it to here. What is this one called? Penicillin V. Penicillin V is already being advanced than penicillin G because it is acid resistant. Okay, what this means, acid resistant? Which means you don't have to take the shots of your butt. You don't need to do muscle injection. You could take oral administration, which means the tablets, you can make it. You can do orally taken. That's really helpful, lots of people. That's penicillin V. But what's the problem? It's still narrow spectrum, which is only effective for gram-positive bacteria. And another thing, because penicillin G and penicillin V, they created, and they use a lot, and the bacteria is smart, they will generate those enzymes to hydrolyze the beta-lactam. Bacteria will create it, lactamase. This enzyme can hydrolyze beta-lactam structure. So which means, what this means? This means antibiotic resistant. That means penicillin resistant. So how are we going to do it? People are really smart. They're going to do something special. Like I said, this part they didn't take because beta-lactam they cannot touch. So what they do? They do something here. Then they go. These are the same. They are adding here. What this tells you? This is a carbonyl group with a methyl. It's a heavy chemical. We call it a bulk here. And do you know what is this? We already said. Methicillin. Well, that's a breakthrough for methicillin. Because when you're making these heavy chemical structures there, makes it more antibiotic resistant. Make it more antibiotic effective. Not easily to be hydrolyzed by the bacteria compared to penicillin G and V. What's the problem? Using too many. Therefore, we have this guy comes out. We have MRSA comes out. That's the reason, because people originally think it's really smart. I have this methicillin. We have a bulkier structure there, make it more effective. Then people keep using it. They use it anytime. When you don't need it, you still use it. That makes it resistant. Therefore, typically when they treat Staphylococcus aureus, they become methicillin-resistant Staphylococcus aureus. That's why the MRSA comes out. And we call it a nosocomial infection because it's come from the hospital. And I want to say this, methicillin, you add these there. This is semi-synthesized. This is not naturally created. This is already chemical synthesis. Now, once the methicillin is become resistant, what people do? People are going to do something else. So what they do? Still at the beginning of here, they don't touch anything for the beta-lactam. That's something they really smart about it. They add stuff here. Then they go beta-lactam. And what is this? That's ampicillin. What is ampicillin for? Ampicillin is started to show broad spectrum activity, which means they can kill gram-negative bacteria because they can attack purine. This is a structure right beneath the lipopolysaccharides. That's ampicillin. But what's the problem for ampicillin? Ampicillin have to be frequently used. You have to do lots of dose. I mean, you have to do it all the time. Because when you use often, it will easily cause antibiotic resistance. So later on, people are also smart. They add a hydroxy group here. Then what is this guy? I bet you know. Your doctor, family doctor, will always give you something like that. If you really have a bacterial infection, this is amoxicillin. But keep in mind, start from methicillin, ampicillin, and amoxicillin. Those are all chemical synthesized, or we say semi-synthesized, which means they originally generated from penicillin, but then they started to do the chemical modification, which is manufactured. It's not natural. Now, what's the amoxicillin's good advantage? Less frequency dose. So, this is the history for the penicillin. And we talk about the structure. Unfortunately, all these people are using way too much. Antibiotic resistance happened all the time. And back to our exam 1, when we talk about the plasmids, remember the all plasmid? That will carry on the information for antibiotic resistance. So, if bacteria has antibiotic resistance for penicillin, what we can do? We can using another antibiotics called vancomycin. We mentioned about this. Do you remember? Clostridium difficile. When we talk about the Clostridium difficile, how we cause Clostridium difficile? Because the old lady in the hospital intensively using antibiotics such as penicillin for about a week cause water diarrhea. The normal intestinal bacteria community in the gut area is broken. And I said the first treatment is very ironic. We using another antibiotics and we using vancomycin. How? Penicillin, because of the beta-lactam, you are going to be attacking the P, BP, which is transpeptidase. So I'm attacking, let's say this guy right here. Okay, I had this enzyme. This is beta-lactam. And it comes from penicillin. They're going to attack the enzyme, but the enzyme doesn't work. If this whole thing not work very well, what I do? I'm going to work on the substrate. Which means I don't let you building these. So I'm going to directly target alanine. That's how the vancomycin is working. So instead of attacking the enzyme, I'm going to attack the substrate. The substrate is target is alanine, because that's an original material for building peptidoglycan side chain. The people use vancomycin all the time. Okay, use too much, cause antibiotic resistance. What we do? Look at your slides. What at the bottom? Basic tracing. Does this chemical sound familiar? We just talked about A disc. Do you remember? Using A disc to differentiate Streptococcus Streptococcus pyogenes and Streptococcus agalactiae. Remember? Remember A disc? That's components is basic tracing. That's how basic tracing works. Basic tracing is saying, you guys are working for enzyme, for the substrate. What I'm going to do, if you guys are not working, I'm going to block the gate. I don't let these chemical material transfer into the cell. That's what the basic tracing do. They prevent the transport of the material using for building peptidoglycan. This is something like I'm going to work inside to kill the enemy. If you guys doesn't work, I'm going to close the door. I don't let all the foods go inside. So the enemy will not have anything to eat, and they will be hungry, starvation, and going to die. So that's what the basic tracing works. And this slide is really very good. It tells you the basic 3 model, how the bacteria go ahead to working to against how the antibiotics go ahead to working to against the bacteria. And at the end, this is inhibit cell wall synthesis. Bacteria can have different mechanisms. Cell wall, protein, nucleic acids, metabolic cell membrane. What is the most effective way? Is inhibit cell wall synthesis. And what is the reason? The reason is very simple, but some people doesn't know. Because bacteria is prokaryotes. They have cell wall. Our human being is eukaryotes. We don't have cell wall. And if we use some drugs is targeting bacterial cell wall, what this means? Which means theoretically it's safe for the human being. Which means side effects gonna be minimized. So that's the important for we talk about these slides. Okay. We get a little bit time, so we're gonna go back to see what the slides tells us. We're spending a time talk about antibiotics. We talk about the penicillin. We draw the whole blackboard. What it talks about. The structure looks like complicated. Then what is antibiotics? If we say very simple, that is metabolic chemical from one microorganism used to kill or inhibit another microorganism. And the first microorganism, most of the time, is fungi. And another microorganism, most of the time, is bacteria. So penicillin created from penicillium, which is a fungi. And then the chemical could kill E. coli, let's say. All the time, when they started, it is natural. Like penicillin G, like penicillin V, those are natural. But later on, when the pharmacy industry, they developed, they building, they manufacture or semi-synthesize these next generation penicillin, like methicillin, like ampicillin, like amoxicillin. That's how they do. But originally, if we go back to the definition, it is a chemical metabolic ingredients from one microorganism using to kill or inhibit another microorganism. Kill, we usually say cydo. Inhibit is static. That's a terminology for that. These two terminology, originally we're going to talk about in our last slides. I already deleted that for the bacterial control because we don't have time to talk about that. But I just want to let you know, cydo means killing bacteria. Static is inhibit bacteria. So here has some example. Penicillin from penicillium, tetracycline from streptomycin. But there is an exception. Sulfur drugs, sulfur-laminates. I believe when you study biochemistry class, you know about sulfur drugs. Sulfur drugs is completely manufactured, chemical manufactured, but we still categorize it into antibiotics. That is exception. Most of the other antibiotics, we talk about tetracycline, penicillin, ampicillin, all those, it is naturally created by fungi. But sulfur drug, sulfur aminates, is manufactured. So that is different. What is antimicrobials? This is natural chemical synthesis, which means you combine everything. This is we already talked about. We already talked about that. So what are other things we talk? Selective toxicity. They can inhibit all bacteria or pathogen and damaging the host as little as possible. We just mentioned about that. Why inhibit bacterial cell wall is most effective. Therapeutic dose, drug level required for clinical treatment. Toxic dose will become too toxic to the patient. Therapeutic index, that is toxic dose divided by therapeutic dose. This number should be the larger the better, or the smaller the better. This number should be the larger the better. The reason is we want the therapeutic dose is smaller the better. We want the toxic dose the larger the better. Now here is something we want to talk about the terminology. We mentioned that earlier. Bacteria to antibiotics we call susceptible. We do not say sensitive. But human being reacted to antibiotics, we call sensitive. What does sensitive means? That means allergy. So a very simple example. Penicillin is not everybody can take. Some people will have allergic to penicillin. The easiest way to do the skin test is you have a tiny dose to see whether there is a swelling comes out. If the swelling comes out, you cannot do it, which means you are sensitive to penicillin. So sensitive is a terminology. Usually we talk about the human being reaction to the antibiotics. For the bacteria reacting to the antibiotics, we call susceptible. Okay, so that's something I want to mention different. Side effects, the undesirable effects of drugs on the host cells. Well, narrow spectrum drugs, we already said, is only effective gram-negative or gram-positive. Broad spectrum, which means work both for gram-positive and gram-negative bacteria. Cidal, killing bacteria. Static is inhibitor bacteria. We have a limited time. We're going to start next with next class. We're going to talk about Kirby-Boer. Kirby-Boer test we will do in the lab anyway. E-test we will briefly mention. Okay, so that's all I have today.